All right, welcome to our last chapter, Chapter 16, Treatment and Rehabilitation in Forensic Psychology. And just as with the prior chapter, I want to just kind of give you a quick content warning that there's some explicit material in here as it relates to child sexual abuse and treatment for sex offenders. So, about 250,000 mentally ill people are incarcerated, and Cook County Jail has become that particular county, which is where Chicago is. That's their largest institutionalized population of mentally ill people. So, forensic psychology can offer therapeutic interventions, direct treatment, and rehabilitation services. So, one alternative intervention is mental health courts, and these are specialized courts that process criminal cases involving people with serious mental illness. And the goal here is to reduce both incarceration for this population and recidivism by linking them with services in the community that will help them address their mental illness. Now, this straddles several worlds: criminal law, mental health, and psychology, and it requires collaboration from people in each field. In 2000, Congress passed America's Law Enforcement and Mental Health Project Act, and this makes federal funds available to local jurisdictions that want to establish or expand mental health specialty courts and diversion programs. And basically, it's designed to promote court-imposed treatment as a substitute to incarceration. Now, there's also an obligation under the ADA, which we talked about in the prior chapter, to accommodate people with mental illness. Now, people with mental illness are vulnerable to assault and intimidation while incarcerated. And prisons are not really designed to be successful in addressing their mental health issues. So as I mentioned, 250,000 people with mental illness are incarcerated at any given moment, usually for nonviolent offenses like trespassing or disorderly conduct. About 16% of state and local inmates suffer from a mental illness, and most receive no treatment beyond medication. And then during street encounters, police are almost twice as likely to arrest someone who appears to have a mental illness. So there's two rationales underlying these mental health courts. One is to protect the public, and the other is to recognize that criminal sanctions have limited effectiveness on rehabilitation and punishment if mental illness is a leading cause of that criminal activity. So the goals of the mental health courts are to break the cycle of mental deterioration and criminal behavior that begins with the failure of the community mental health system, and then to provide effective treatment options instead of criminal sanctions. Now, there are requirements that are important for the operation of mental health courts. First of all, we have to train everyone in that courtroom work group on how to deal with mental illness. So that's judges, prosecutors, defense attorneys. Participation needs to be voluntary. Otherwise, this violates the Equal Protection Clause or the ADA. Defendants need to have permission to withdraw and have their case heard in a criminal court. We want defense counsel to have a background in mental health. The courts have a continuing jurisdiction over a defendant while they're receiving those therapeutic services, and they sign a service plan that not only talks about what kind of services they're going to receive, but also what actions will be taken if they don't comply with their end of the bargain. Now, another alternative intervention is alternative dispute resolution, and this is seeking a mutually satisfying outcome. Now, advantages here include that it's speedier, it's more flexible, it's more responsive to personal issues, and less expensive. And this includes negotiation, mediation, and arbitration. Mediation uses a third party to facilitate a settlement, whereas arbitration is an adjudicatory process, and the third party is deciding the actual outcome. Now, what about treatment? What about treating victims of domestic violence? About 22% of surveyed women and 7% of surveyed men report being physically assaulted by a current or former intimate partner in their lifetime. And every year, 1.3 million women and 835,000 men are physically assaulted by an intimate partner. Victims of domestic violence often experience intimidation, loss of control, hopelessness, intrusive thoughts, and they often psychologically relive the abuse. This can result in stagnation, feelings of being trapped, and accommodating the abusive situation. Now, ideally, you'd want to be able to treat both the victim and the offender. And in cases of physical and sexual abuse of children by a parent, we also want to make sure that we involve the siblings in treatment. So it's not uncommon initially for victims to look to informal sources for help: friends, family, loved ones. before then looking for formal sources like shelters and 24-hour crisis hotlines. Now, batterers also use finances as a mean of controlling their victims. They might deny them access to money or not allow them to work. They may harass their victims at work until they're fired and damage their homes until they're evicted. So we have a variety of responses here. We can use transitional housing programs, which offer an alternative living situation for battered women. Healthcare interventions can include emotional support, mental health counseling, safety planning, legal advice, and consistent documentation of the abusive behavior. Legal advocacy is exactly what that sounds like. It provides a legal advocate to act as a liaison between the victim of domestic violence and first response teams. So those are other people that are providing advocacy and support at the time of the violence. Now, treating perpetrators of domestic violence, we see a high rate of antisocial personality disorder. Now, remember, we've talked about this before, and it's got a wide range of characteristics that you can easily see here. And as I mentioned before in class, this is generally regarded as untreatable. In fact, those who are treated actually become better psychopaths. And recidivism occurs most often in psychopaths who have the ability to convince their therapist that they've made good progress in treatment. All that treatment helped them do is sharpen their skills at conning others. Now, when someone experiences violent crime or trauma, this violates ontological security. And that's that stable mental state we have from a sense of continuity with regard to the events in our life. It's a sense of order in the absence of chaos. Now, victim services can be very helpful here, especially for victims of sexual assault, domestic violence, and for children. And there's three major components here. What's the emergency response at the time of the crisis? So that could be when a victim of domestic violence or sexual assault shows up at an emergency room. How we stabilize that victim in the immediate days following the trauma, and then how we mobilize resources in the aftermath of that crime. One thing to keep in mind if you're a first responder to these kinds of cases is we want to hear the victim in an understanding, sympathetic, non-judgmental fashion. We don't need to press for details right away. We want to instill a sense of safety, comfort, and trust. About 19% of rape victims attempt suicide, 44% suicidal ideation, and 16% report that they had a nervous breakdown. Now, victims of violent crime may also experience PTSD. And that's going to vary how susceptible someone is to that based on demographic factors, psychological factors, and environmental factors. Now, psychological reactions to violent crime include sleep disturbances, irritability, depression, anxiety, alcohol and drug abuse, suicidal thoughts and attempts, and PTSD. And PTSD symptoms include intense fear, feelings of helplessness, agitation, re-experiencing the traumatic event, avoidance of stimuli associated with the trauma, emotional numbing, distress or impairment, and important areas of functioning. So psychotherapy for PTSD often involves facing those memories and images. Those who do decide to press charges and testify in court might find that PTSD lasts longer for them because the process of the criminal justice system takes a long time. But it can be very therapeutic to request restitution or make a victim impact statement. Now, how do we treat child abuse offenders? The most common approach to this is psychoeducational. So it includes things like parenting classes and anger management. Now, parent-child interaction theory is coached behavioral parent training that trains parents of specific behavioral parenting skills using live sessions. So it teaches things like how to praise, how to use timeouts, and it's highly effective in decreasing child behavioral problems, and the improvements seem to be maintained over time. Cognitive behavioral therapy is also very popular, and this addresses things like views on violence and physical punishment, parents' expectations, self-management, and child behavioral management skills. This may also involve family therapy, which focuses on parent-child interactions and parent-child problem-solving routines. Now, these programs do show less parent-to-child violence, and the effectiveness of this is limited unless it's reinforced by structured home visits. Now, what about treating child sexual abuse offenders? Child sexual abuse produces long-term psychological problems: depression, guilt, substance abuse, anxiety, long-term problems, fears, phobias, and even suicide. So if you think about it, it sounds a lot like PTSD. Now, in the 1950s, the way we treated sex offenders was through aversive conditioning, and this used classical counter-conditioning paradigms. You would pair a noxious stimuli, like a mild electric shock or a bad odor, with repeated presentations of the sexual stimuli depicting children. And the idea here is to associate the disgusting thing with the disgusting thing being child pornography. This can be overt, where we apply it in real life, or covert, where you ask the subject to imagine an averse stimulus, like imagine someone walking in on you and discovering you. Now, other behavioral techniques include satiation, thematic shift, and let's talk about each of these. So satiation, the subject masturbates to ejaculation while verbalizing aloud variations of their pedophilic fantasies. After ejaculating and through that refractory period, they're instructed to continue masturbating to the same fantasies over several long sessions. And essentially, there is a masturbatory reconditioning that happens, which involves associating sexual arousal with adults. Now, using thematic shift, the subject masturbates to, again, that pedophilic sexual fantasy until the point of orgasm, then switches to a sexual fantasy about an adult. Now, these can change sexual arousal, but we don't know how long that change lasts. And generally, we measure the success of sex offender treatment by recidivism rates, because the primary goal is to reduce future victimization. Now, some research tells us that treatment does reduce recidivism, and most programs operating on cognitive behavioral therapy include relapse prevention as a connective theme. So generally, they begin with the offender has to acknowledge at least some part of the offense. And then the program helps them to increase victim empathy, change distorted thinking patterns, improve their social skills, teach self-control, and develop lifelong self-management strategies. Subjects would also develop detailed plans for avoiding relapse and managing risky situations and urges. Now, there's several research projects that have looked at this. Now, a 2003 study said that after 6 years, the reoffense rate for offenders who completed treatment was 5.4%, as opposed to 30.6% for partial treatment and 30% for no treatment. Those who had aftercare had even lower recidivism rates. Now, in 1997, Alexander did a meta-analysis of 81 studies and found that those who received treatment while in prison had a 9.4% recidivism rate, compared with 17.6% for those who did not attend any treatment. Now, Loss points out that relapse prevention is not well suited to some types of sex offenders, because not everybody is operating under the same type of relapse. Relapse is not always triggered by negative emotions. Not all offenders are basically trying to actually avoid offending. Now, there's some other treatments that we can do as well that target hormones or neurotransmitters. Anti-androgens interfere with the action of testosterone. And the most well-known of this is essentially chemical castration and Depo-Provera, the birth control drug that's given to women. Only 1 in 6 studies of Depo-Provera showed an effect. Now, you might also look at central hormonal agents, which inhibit the production of testosterone. And this has shown some success. Now, surgical castration permanently reduces sexual response by removing the testes. This is rarely performed now, though. So 9 states require chemical castration or surgical castration for those who want to be paroled and released. But the procedure does appear to be effective at reducing sexual desire. Now, how do we treat those who have PTSD while they're in prison? Well, the rates of PTSD are particularly high in prison inmates. Among male inmates, it's as high as 21%. Among female inmates, 48%, and 65% among male juvenile offenders. And treatment usually consists of exposure and desensitization, cognitive and cognitive behavioral therapy, which we've spoken about, and skills-based therapy. So one type of intervention here is EMDR, eye movement desensitization and reprocessing. So basically the client is going to focus on the traumatic material And then at the same time, there is saccadic rhythms. So this is basically your eyes moving left to right, following the hand movement of the therapist. Subjects are taught to identify and cognitively restructure problematic beliefs related to traumatic events in order to process this. And this is repeated until there's a low level of distress. And it appears to be fairly effective in treating PTSD. Automatic incident reduction is a sensitization procedure using repetitive guided imagery of the traumatic offense. And the session ends when the client no longer experiences stress associated with the trauma and cognitive distortions have been restructured. And this appears to be fairly effective as well. Now, cognitive treatments, studies that have used cognitive behavioral therapy and expressive therapies for male juveniles with PTSDs consisted of check-ins, psychoeducation, relaxation training, and trauma-related art therapy. And the subjects in this study did report improved coping skills, sleeping, and anger management. And this has also been effective in treating victims of sexual assault as well. Now, skills-based approaches, we have two studies here. One develops an integrated therapeutic approach that emphasized self-control called Seeking Safety, and the women attended 14 90-minute group sessions, and they did report a significant decrease in their PTSD symptoms. Now, another program was 10 2-hour sessions that focused on skills and hypnotic skills such as relaxation, containment, and affect modulation. Now, what about victims or survivors of terrorist attacks? Now, this has the features of both a criminal assault, a disaster, and an act of war. And many survivors feel isolated from those who can't understand what they had gone through. Now, 2 months after 9/11, 11% of all New Yorkers showed signs of PTSD, and that was 3 times the national average. And interestingly enough, it was most strongly related to the amount of TV coverage watched. Now, survivors may have frequent nightmares of imagined deaths of a victim they knew or wish fulfillment fantasies of rescuing victims. So again, first responders should obtain as much information as possible about the crime itself and avoid empty statements. Don't say things like, everything will be all right. Offer concrete, realistic information. So information that you might have of where people can get information, what are next steps for them, if you've got information for referrals, and provide understandable education about the onset and course of possible post-traumatic symptoms. Normalize for them that this experience, not the experience of terrorism, but the stress reaction is normal. Now, you might also undergo individual psychotherapy. And here our goal is going to be to provide empathetic support and normalization as we build some rapport and some trust with your patient or your client. Survivors should also be prepared for emotional, financial, practical, and social losses that follow. Therapists can also begin to educate family members as to what they can expect and try to dispel any unrealistic expectations. So again, concrete information like victims' resources. But also don't give people too much information too quickly. When trust has been developed, you can now work on things like relaxation techniques, desensitization, and the same things that you would do for PTSD. Writing can also be therapeutic. And your book talks about the hearts models. So listening to the person's history, and that's basically active listening, focusing on their emotions, asking about symptoms, explaining the reason for symptoms, teaching relaxation and coping skills, and helping with self-change. Now, family members can both be helpful and they can also make situations worse. We also want to remember that successive traumas are often cumulative, and while someone may come to you for an acute trauma that they've just experienced, whether that's being the victim of terrorism or a sexual assault or a violent crime, they may also have other issues that they're already dealing with. And so we might have to address those things as well. Now, there's also stress associated with military deployment. So this means obviously extended separations and the uncertainty of having someone you love in a combat zone. More than 30% of all soldiers meet the criteria for mental disorder, but less than half actually seek help. And there are factors that can exacerbate this stress. So families that already have problems, young families for whom this is their first separation, and families who recently moved to a new duty station. And there are barriers to accessing quality mental health care. Right now, there's a 40% vacancy rate of active duty psychologists. So there's just not even enough psychologists to help our active duty service members. There's also a lot of stigma associated with this, and people often don't want to reach out for mental health help. Now, there are preventative actions that can be taken. We can educate military leadership about the importance of these mental health issues and take measures to reduce the stigma. So perhaps whenever someone returns from deployment, there should be mandatory mental health services. We need to do more research on these issues, and we need to attract and retain more qualified psychologists. Now, what about when we've got someone who's been deemed incompetent to stand trial? Less than half of patients who have been deemed incompetent were actually provided any treatment. Now, individualized treatment, where we educate you about your legal rights, combined with group treatment, can be useful in restoring someone's competency. But also, cognitive issues may come into play. So mental retardation can also be a factor. This is low intellectual abilities and impairment in functioning in major areas of life. And so about 6% of adult defendants who were considered incompetent were also mentally retarded. Now remember, in Cell v. US, the Supreme Court held that we could force medication for incompetent defendants to restore their competency. And that wraps up our very last lecture.